Hi, and welcome back to More Health, Less Healthcare. I'm your host, Peter Boland. Today, we're going to look at a health plan that many consider one of the best in the country, Blue Cross Blue Shield of Massachusetts. It's a terrific case study, one of the best of the Health Equity Case Studies Handbook. And it comes in two parts. Today, we're going to look at what the plan's doing. And the next podcast will focus on what they've learned from their customers. It's enlightening and it also raises some fundamental questions about the limits of the traditional approaches to risk management, benefits design, and whether health equity is a realistic goal given the constraints of an extractive business model. So let's look at today and the next week and lead into a very interesting discussion. Blue Cross Blue Shield of Massachusetts is a nonprofit. They cover about 3 million members, and they've made some very public commitments to four big programs: food justice, environmental justice, racial justice, and equity-linked payment reform. If you're going to design a good health plan inside of our current system, Blue Cross Blue Shield of Massachusetts might be close to your model. But here's the tension that I want to explore. What are the real strengths of this model? And what are the limits of even a high-performing, mission-driven health plan? And what happens when you try and do good inside an underlying business model that still depends on extracting value from illness, from complexity, and certainly administrative control? In other words, is a case for a blueprint for health justice, or is it an example of how far we can go without changing the underlying game? That's a basic question. So let's walk through what they're doing, why it matters, and where the structural contradictions begin to show up. So in part one, what's BCBSMA actually doing today? And let's give Blue Cross Massachusetts their due. This is not a check the box CSR, the corporate social responsibility plate. It's a reasonably integrated corporate citizenship and payment strategy. So first, health justice as a frame. Blue Cross has publicly framed its corporate citizenship around three big drivers: food justice, environmental justice, and racial justice. They've committed ongoing dollars and staff time to community partners with multi-year grants, training, and pro bono support, not just one-off sponsorships. They position themselves as a community convener, using their brand and capital to bring together nonprofits, community groups, and local governments around shared projects across the state. Second, food justice and food security. And instead of sprinkling tiny grants everywhere, they've clustered efforts into a food justice portfolio. These include three things: supporting regional food banks and distribution hubs on the South Shore, so 18 communities can access fresh, culturally relevant food more reliable. Partnerships with organizations like Project Bread, Boston Area Gleaners, and local farms to connect surplus food and local agriculture to schools, food pantries, and low-income families. Creating programs where corporate leftovers and local farm produce are repackaged into meals for community college students and families who are food insecure. And they also run corporate gardens and farmers markets at their sites. They're launched .rx, a prescription for living program at Codman Square Health Center in Dorchester. Again, connecting families to coaching, YMCA facilities, and healthy food through a prescription written right in the exam room. They're touching immediate hunger, long-term food systems, and clinical integration. Third, environmental justice and sustainability. On environmental justice, they fund community organizations in places like Chelsea and East Boston that are heavily burdened by industrial traffic, fuel storage, and airport-related pollution. And they support youth junior farms and climate nature training programs. Internally, they've reduced energy, water waste, and paper use substantially. over the last decade, signaling they are very committed to environmental stewardship as an essential part of health. This is novel. Fourth, racial justice and vaccine equity. On racial justice, three more things come to note. A racial equity and justice grant program focused on BIPOC-led nonprofits with multi-year funding, a major grant to the Commonwealth Racial Equity and Social Justice Fund, led by Black and Brown business executives, strengthen community voice and guidance in research and clinical trials, and targeted vaccine equity efforts during COVID, including transportation, Vax Express, mobile vaccination trains, and partnerships with groups like Equity Now and Beyond to run clinics and outreach in immigrant communities. They also opened a Spanish language call center and expanded their website into multiple languages, Spanish, Portuguese, Russian, simplified Chinese, Vietnamese, to reduce language access barriers. And fifth, equity data and payment reform. The most structurally interesting thing they've done is around measurement and payment, two critical variables. They analyzed data for about 1.3 million members and found racial and ethnic disparities on 40 plus quality measures, things like colorectal cancer screening, adolescent well care visits, antidepressant management, and severe maternal morbidity. And they made these inequities public and linked them to a commitment to incorporate equity measures into their value-based payment model. This is really important. Starting in about 2023, they committed about $25 million to physician groups and hospitals in their alternative quality contract with explicit incentives to reduce racial inequities in areas like, again, colorectal cancer screening, blood pressure control, and diabetes cares. Providers can earn more if they close equity gaps while maintaining quality and efficiency. So you have a health plan saying, we'll literally pay you more if you reduce inequities in care for marginalized groups. And sixth, healthy living, fitness, and youth programs. Layered on top, they've built healthy living initiatives. Two things, grants and training programs for organizations to improve healthy eating, active lifestyles, and healthy environment. Second, park-based fitness programs in Boston, Worcester, Lowell, and other communities. Free classes across multiple languages, youth summer camps and leadership programs like Camp Harborview, and physical activity programs embedded in schools and senior citizens. And they mobilize their own employees with large-scale volunteer days, board service, pro bono work. In recent years, they've dedicated millions in community investments and tens of thousands of volunteer hours. This is really commendable. So at first glance, this is a kind of plan with most health equity advocates would wish insurance would do and do more of. But let's turn to part two. Why does this matter? And let's step back and name the real strengths here, grouped into a few core buckets. A, data transparency and accountability. First, the willingness to measure and publish inequities is a big deal. Very few have reached this stage of accomplishment. Blue Cross Blue Shield took internal administrative and clinical data, stratified it by race and ethnicity, then told the world our Black, Hispanic, and some Asian members are getting lower quality care on dozens of measures. That moves inequity from a vague moral concern to concentrate performance issues. It lets communities, employers, and regulators say, you've shown us your gaps. Now we're going to watch what you do about them. To me, this is a first. B, aligning dollars with equity. They didn't just stop at measurement. They linked money to closing the gaps. By building equity metrics into their value-based contracts, they create a business case for health systems to invest in outreach, navigation, translation, and redesign care processes. If you're a large health system CFO, an equity neutral contract is easy to ignore. An equity-linked contract backed by tens of millions of dollars is harder to dismiss. That's an important shift from rhetoric to incentives. C, community-based multi-year partnerships. Their community work is not just scattered micro grants. They're doing multi-year, multi-partner collaborations around food systems, youth development, and environmental justice with real dollars and some staying power. So that's closer to what it takes to shift local conditions, consistent funding, technical support, and a willingness to let community organizations lead, and that is critically important. D, integration with clinical touchpoints. Programs like .rx show an understanding that social needs have to be integrated into clinical workflows, not just outsourced to charities in the community. When clinicians can literally write a prescription that connects a family to healthy food, coaching, and safe exercise, you're starting to align the exam room with the neighborhood. This too is critical. E, internal culture and environmental stewardship. Finally, there's a signal effect in what they do internally, cutting water and energy use, reducing waste and paper, expanding language access, and mobilizing employees as volunteers and board members. It says equity and environment aren't just things we fund out there, they're part of how we see ourselves as an institution in a community. So if you list these elements, data transparency, equity-linked payment, community partnerships, clinical integration, internal culture, you see why people hold up Blue Cross Blue Shield of Massachusetts as a leading example. So, part 4, the cons. What about this model that can't do? Well, let's turn to the limitations, not of the people or the intentions, but of the underlying conventional health plan strategy and extraction-based business models. I want to group these limitations into 3 big buckets, and each are key. First, the 2 ledgers problem. On one ledger, you have generous community investments, grants, and pro bono work, tens of millions of donated time across food and environment, racial justice, and healthy living. On the ledger, you have these core business, collecting premiums from employers and individuals, negotiating prices and benefits, managing utilization through prior authorization networks and benefit design, and earning margins and reserves by spending less on care than they take in over time. So even as a nonprofit, the health plan must generate surpluses, must build reserves, must satisfy rating agencies, and keep the premium growth, quote unquote, manageable for employer customers. And the structure still rewards lower utilization in the aggregate, tight control over which services are authorized and at what price, and designs that shift costs and responsibilities to patients and employers. Now, in that context, the community portfolio can never match the scale of the harm and friction created by the core business model. You can pour $40 million into grants, while premiums for small employers and individuals basically remain unaffordable. And benefit designs continue to expose patients to high out-of-pocket costs. So you get the split, the good work side and the business as usual side. They coexist, but they rarely change each other's fundamental logic. And that is a critical point. Second, equity as a performance niche, not a system design. By putting equity measures into value-based contracts, Blue Cross Blue Shield of Massachusetts is absolutely pushing the field forward. But structurally, equity remains a subcategory of performance, not the design principle of the whole system. providers are now asked to hit targets on quality, cost efficiency, and equity. That's progress, but it keeps equity within a metrics and bonus frame. It does not automatically change three fundamental things. Who owns and governs the plan? Who holds real power in the design of benefits, networks, and policies? Or how resources flow between profitable and marginalized population. I want to emphasize that again. How resources flow between profitable and marginalized populations. In other words, we're still optimizing the let me say it again. In other words, we're still optimizing the existing game, not changing whose game it is. That's also a measurement risk. When equity becomes a narrow set of tracked indicators, systems may chase the measures while leaving unmeasured inequities untouched. Now, Blue Cross Blue Shield of Massachusetts have tried to guard against gaming, but measurement by definition narrows attention. There's no way around that. So third, the extraction model underneath. Even with equity incentives, the fundamental health plan logic is still extractive in nature. The plan's just between people and care, collecting and allocating money. It profits financially or in surplus from administrative complexity, from information advantages, and from the ability to say no or not yet to certain services. It has enormous influence over which providers thrive and which don't, often reinforcing hierarchies and provider consolidation. And I'll leave it to you to decide how successful consolidation has been in any market in the country. That's a topic for another day. So Blue Cross Blue Shield may use this power more thoughtfully than many, but the structure is the same. Communities and patients remain largely on the receiving end of decisions made by corporate and provider executives. So when you see them fund environmental justice in communities like Chelsea and East Boston, you have to ask, are we using a small share of premiums to mitigate harms that the larger healthcare and economic systems continues to impose on those same communities? When a plan funds vaccination access, transportation, outreach during COVID, for example, is that filling gaps created by decades of disinvestment in public health infrastructure and primary care? And I want to emphasize decades of disinvestment in public health infrastructure and primary care, because the answer is often yes. The plan is smoothing rough edges of a system that still depends on sickness and fragmentation for its revenue. That is a key point. The plan is smoothing rough edges of a system that still depends on sickness and fragmentation for its revenue. So part 5, the paradox of doing good inside the plan. And this leads to what I'd call Blue Cross Blue Shield Massachusetts paradox. On the one hand, they're doing many of the things we've asked health plans to do: measure inequities, publish them, link dollars to improvement, invest in food systems, environmental justice, racial justice, partner with community-based organizations and support BIPAC-led groups, integrate social needs into clinical care through programs like DocRx. On the other hand, all this happens within a financing structure that relies on employers as primary buyers, operates inside a competitive market where plans protect their brand, their risk pool, and their margins, has limited ability and limited incentive to attack the biggest drivers of poor health: low wages, unstable housing, structural racism, and employment and education, or the financialization of the healthcare industry. And the financialization as a topic we will address in later episodes, which is a key component that we want to learn more about. Even their most innovative move, equity-tied payment, still uses the existing provider power map. They're not asking, should communities own and govern the plan? They're saying, we will pay your existing systems more if you reduce inequities for our numbers. That's good, right? It's a bit like putting solar panels on a factory that still pollutes the river. The panels matter, they reduce harm, but they don't change what the factory is fundamentally built to do. Because Blue Cross Blue Shield Massachusetts is seen correctly as one of the good actors, there is a risk that the story becomes a ceiling rather than a floor. I want to say it again, a ceiling rather than a floor. And this applies to every health plan around the country. Look, here's the best a plan can do. If we just replicated this out everywhere, we'd be fine. Well, I disagree with that. We might end up settling for a world where high-performing plans fund food banks and equity grants, while the underlying logic of the premium growth, cost shifting, and financial extraction remains untouched. So, part 6, what does this case teach us? How should we read this case? And I encourage you to read the entire case in the handbook. It is definitely worth reading. I suggest maybe 3 main takeaways. First, this is the leading edge of what a conventional health plan can do. Blue Cross Blue Shield Massachusetts shows what's possible if you take a traditional health plan and push it towards health justice. You can use data and payment to reduce specific inequities in care. You can deploy meaningful community investments to strengthen local food systems, environmental resilience, and racial justice organizations. You can integrate social needs into clinical workflows and support language access and vaccine equity. For many markets, just reaching this level would be a major step. I don't want to discount this point. This is a major step forward. Number 2, but it's not structural transformation, and that's the point. At the same time, this is not structural transformation. The ownership, governance, and basic business logic remain the same. Premiums in, claims out, administrative control in the middle. Equity becomes a performance dimension and a marketing story, and a good one, but not the organizing principle of the entire financing system. The plan still extracts value from being the gatekeeper of payment, even as it recycles a portion of that value back into community programs and equity initiatives. So, number 3, we need both better plans and new models beyond the current plan structures that we work with today. And the lesson isn't to dismiss this work. The lesson is put it in context. So I think we need at least 2 main changes. Plans like Blue Cross Blue Shield of Massachusetts to keep pushing the boundaries of what can be done inside the current model. But we also need experiments outside that model, community-governed funds, public options, regional global budgets, and other designs that reduce the need for intermediaries to extract value in the first place. There are pain points along the entire system that are extractive in nature. And that is an important point that we're going to focus on in coming episodes. Blue Cross Blue Shield Massachusetts, the story should be a floor. If you're a health plan that wants to talk about equity, this is a minimum level of seriousness. But the ceiling is much higher, and it probably lives in models where communities themselves control more of the money, more of the data, and more of the decisions. So, in closing, where does this leave us? If you're a leader in a health plan, the Blue Cross Blue Shield Massachusetts case study is both encouraging and challenging. It says you can measure inequities, you can put money on the table, and you can deploy corporate citizenship in more strategic ways. If you're a community leader, it's a reminder to welcome the resources, but do not confuse them with structural power. Grants, incentives are unhelpful, co-ownership and co-governance are transformative, and that's the point. If you're a policymaker or employer, the question becomes, are you satisfied with the best that we can do inside the current model? Do you want to finance health in ways that don't depend so heavily on plans being benevolent intermediaries. Now, in future episodes, we're going to look at what these alternative models might be and how employers, communities, and clinicians can start to build them. So, thanks for listening to More Health, Less Healthcare. If this conversation raised questions for you, or if your organization is wrestling with similar tensions, I'd love to hear from you. So before I go, I'll leave you with one question. If a health plan like Blue Cross Blue Shield of Massachusetts is doing almost everything right within the current system, what would it take for us to change the system itself? So next week, we're going to dive into the consumer side of the business. It's an interesting set of issues that we're going to look at. So thanks for joining us today, and email me your thoughts on LinkedIn or at peter@bolandhealthcare.com. Thanks for listening.